Thank you so much to the Congress organizers for inviting me here today to talk to you a little bit about real-world evidence and big data analytics. So I'm an epidemiologist in Maccabi Tech Research Institute for Research and Innovation based in Tel Aviv in Israel. And what I'd like to share with you today are some examples about our experience in collecting and analyzing data, in working together with physicians, patients, academia, startups, and industry to bring value from that data. And then to show you a little bit about how we implement that in daily clinical practice and what wider implications this can have for policy and practice. We'll briefly go over the Israeli health system to see similarities and differences with the Greek system, which itself has undergone and is undergoing a lot of changes. And then we'll go through several case studies to highlight examples of real-world evidence and big data research. Just briefly, in Israel, we have a system of mandatory universal health insurance, which was put in place in 1999 with the National Care Act. And it's a model of managed competition between 4 health funds. Every citizen is free to choose between the health funds and to switch between them. Actually, they rarely switch between them because they're able to get the same basic basket of services in each of the 4 health plans. Where the competition lies is primarily on the quality of care, and then also on supplementary voluntary health insurance that can be obtained if they choose, also within the health plan. So it's an integrated payer and provider. In terms of the funding, we have a mixed model with an earmarked health tax that comes out 4.8% of the income, which is added some general taxation. These taxes are pooled, and then the health funds are financed primarily by the government through a formula of age-related capitation. Health expenditure in Israel is on the lower end of the spectrum, and when we look at our OECD partners, and that's both when we look at a percentage of GDP, but also when we look in absolute terms in US dollars. Nonetheless, the health status is relatively good. What stands out in the population in Israel is that among 8.8 million members, we have a very young population. Only 10% are over the age of 65. And we're also experiencing the effects of population aging, but maybe at a slightly lower rate because of the high birth rates and also high immigration rates that keep the population quite young. There are high rates of healthcare utilization and quite good immunization coverage. What does stand out, though, is a shortage of hospital beds, and that has also been a drive to strengthen the primary community care and keep people out of hospitals. The community care, you can see, divided into the 4 health plans, is not divided equally, and Maccabi represents about a quarter of the population here. It's the 2nd largest health plan, and today that corresponds to over 2.3 million members. We have about 5,000 physicians. Most of them are independent contracted physicians. And again, though patients are free to move out and move between the health funds, they rarely do, and about 1% of members move out every year. This is a healthcare services research network in the United States, and Maccabi is the only non-US partner in that organization. What that means is it can give us a little bit of a benchmark to compare the size of the database. In terms of size, it's quite comparable to some of the biggest HMOs in the United States. But what stands out is the retention rate. So because the insurance is not linked to employment, we're often seeing patients that stay from birth until death in the database, particularly because we have electronic health records that were initiated in 1993. We have over 20 years of longitudinal data to follow those patients all the way through their life course. The electronic health record is really the core feature here. Now, first of all, again, because we mostly work with contracted physicians, so we really need a good way to communicate, to connect them, to be able to manage patients, and also to provide decision support tools. Beyond that, we have this health information and data at the bottom, which is mostly even just a bonus and a byproduct of this. Every interaction between the patient is computerized in this setting. patients have a magnetic card that they swipe whenever they visit their physician. Whenever they go to the pharmacy, they can they can see their electronic prescription when they swipe their card. Beyond that, through their patient portal on the website or on the app, they can make an appointment, they can view their list of prescriptions. They can also, if it's a chronic treatment, they can put in a request to renew their chronic prescription without having to visit their physician. And they can then go pick it up in the pharmacy without any piece of paper or additional interactions with the physician. From the physician's side, the portal is crucial to help manage the patient's data, but also it provides assistance in terms of alerts and reminders that can be put in place that help to process all this data to guide the physician in his decision making and summarize the information. All of the data that you see here flow automatically into one central database. So we have data from the electronic health records, which is physician diagnosis from outpatient visits, for example. We have the prescription data, but we can also see who went out and purchased this data, dispensed their prescriptions in real time. From hospitals, we can see the discharge diagnosis, the procedures that were performed, and one key feature here is the central lab. So although there are several collection points across the country, at the end of the day, they all arrive to one lab in the center of the country, and that helps when we're talking about research to have data that all comes from the same standardized procedures. Of course, this is really a fertile ground for research, and that drove the development of the Maccabi Tech Institute, which has been growing in recent years. It started with the Epidemiology and Database Research Unit. Since then, we've integrated with Clinical Research Branch. And there's often a lot of overlap between the two, where you can identify patients in a database study using retrospective data that was automatically collected for clinical purposes. And you can use that to identify patients that would be eligible for your clinical trial. And beyond that, you can then contact their treating physician. You can contact the patient to see if they would want to be recruited for a clinical trial. The newest addition to the Research Institute is this Morris Kahn Maccabi Big Data Institute, which was made possible thanks to a generous donation by Morris Kahn. And the most recent project, which we'll touch upon as well shortly, is the Biobank project, which harnesses the existing infrastructure of the collection and processing of lab tests to collect additional data that could be used for research on genetic data and biomarkers. And all this is moving towards personalized medicine to help improve patient outcomes. The first layer above the electronic health records data is one of patient registries. So the cancer registry exists at a national level and is managed by the Ministry of Health, but all these other registries were established within the health fund, and they were established really due to need that arose in clinical practice. So for example, when we talk about diabetes, there was a need to validate the diabetes population to help manage those patients and track quality measures. And what it does is it just draws from the data that's collected automatically, be it the laboratory tests and the diagnosis from the physician records, and also the prescribed medications, and using a case algorithm that's based on the international clinical guidelines, you can get to a more validated population so that you don't end up flagging a patient that has had just one abnormal test or just one diagnosis of suspected diabetes. You can define a population that is more specific to help you better manage those diseases. In terms of research, that allows us to track the epidemiology of diseases. Here you can see by age and sex. You can also monitor that over time. The implications, you can also translate resource utilization into estimates of direct medical costs associated with those conditions. And because the populations remain defined according to clear, transparent criteria, you can easily monitor changes over time. I want to share with you one example of the most recent registry in Maccabi, which is the Osteoporosis registry. Now, the other registries draw from data that is quite routinely collected, structured data that flows into the database and is linked on the national ID number. But in the case of osteoporosis, what we really need to be able to identify the population is the bone mineral density scans. And this is something that was not available in our setting. The BMD data from the hospitals was stored in PDFs because there had previously been no need to add it, to link it to the other data. And this is an example of how research really helped to change practice and action. So this project started as a small-scale research project in collaboration with Merck Pharmaceuticals, who provided financial support to really tackle this mountain of PDF files and try to extract from there the BMD data that could be then stored into a form that we can link and analyze. Once we link it with the central database, it means that we can look not just at patients who have pathologic BMD, but we can define osteoporosis based on other criteria. If you look here at the table, about half of the registry didn't have any indication of osteoporosis based on their BMD data. There are actually lots of women, especially, who had typically osteoporotic fractures, for example, hip fractures, who had not been captured. Or even patients who entered the registry based on medication alone. So even though they were prescribed osteoporosis medication, they were lacking the diagnosis code and they were lacking data on their BMD scans, and so they might not have been picked up by previous estimates. And this revealed a burden of osteoporosis that for men was quite similar to what we might expect, and it's actually very similar to what I saw in a great study from Greece in recent years. In Greece, you had about 1 in 15 men with osteoporosis. Here was 1 in 16. The difference lies in the burden among women. So in the study from Greece based on BMD data, there was about half of the prevalence of osteoporosis. But from this, we can see that it seems that that overall 50% of osteoporosis among women may be undiagnosed and might not be captured if we're looking at BMD data alone. And if we are able to link these different data sources, look at fracture history, for example, we can flag these high-risk patients. And in this setting, we were in a unique position to then close the loop, get back to the patients, and implement this registry in clinical practice. And what this means is that from just a small-scale research project, we could extend this to have an osteoporosis registry that updates itself automatically and flags to the physician patients who are identified with osteoporosis. We can then track their quality measures and outcomes, and even look at specific questions such as what are the consequences of non-adherence to treatment. And in fact, in this one study, we found that half of the patients were not adherent to their treatment with oral bisphosphonates, and that led to 20% increased risk of fractures, substantially increased costs, particularly among elderly patients. And so what we were able to do is then use that data to provide a rationale for creating rule-based alerts to go back to the physician and flag these patients and say, here we have someone at high risk who is untreated, or here we have someone at high risk who should be screened for BMD or who should be referred to an endocrinologist. And within just 8 months of implementing these alerts, we had over 2,000 patients who initiated treatment for osteoporosis as a result of that. I want to share with you also a few examples of how real-world evidence research can be used to support decisions when we're talking about implementing new health technologies at different stages in the process. So in an early stage, what we really needed are data on the disease. How many patients are they? Who are they? What comorbidities do they have? In the next stage, we need to know a little bit more about the existing technologies, what are the treatment patterns and outcomes, and get a baseline. And once we have something post-marketing, we're interested in questions of safety and of outcomes and comparative effectiveness studies. And I want to share with you a few examples of the value of this kind of research. Our first example here is a burden associated with human papillomavirus. Now today we have about 20 countries that have implemented or are about to implement vaccination policies among young boys as well as girls. And a lot of that was based on studies such as this one. This is a study from 2012, which were able to show that the burden associated with HPV was not just with cervical cancer, but also with genital warts, which affects men as well as women and are associated with significant impact on the quality of life. And these data were used to inform policies not just in Israel, but also internationally. Briefly, a quick example here about the potential for using prescription and purchasing data. We have here examples of statin use where we were able to look at changes in the proportion of the population who were statin naive, who had never taken statin. And what we could see is diminishing pools over time. So at a certain point in time, almost everyone at high cardiovascular risk received the treatment that they were recommended. However, over time, we could see a shift to more and more primary prevention among younger patients with lower cardiovascular risk. And we could then also link that with laboratory data to see how does adherence to statins, how does the prescription, and particularly in this case the purchasing data, correlate with what we see in the declines in LDL. And this study showed, for example, that a clear correlation between adhering to your statin treatment and reduction in LDL. And it suggests that when we see a purchase, then we can assume that the patients are actually swallowing the drugs. And beyond that, it allows us to track the outcomes and quality measures in terms of more in the immediate in terms of their LDL reduction. And we're talking about long-term outcomes, we can ask broader questions as to what are the benefits not just for reducing cardiovascular events, but also the wider range benefits such as reducing all-cause mortality or many other effects that we might not have considered previously. In terms of influencing decision-making, I want to share with you an example here from hepatitis C. In 2013, there was an urgent need for data on the disease burden and the effectiveness of the current treatments. In Israel, very little was known about the burden of disease. And so with these first studies revealed that although the incidence is declining like the rest of the world, actually there was over 10,000 patients who still had hepatitis C. Most of them were not drug users. They were infected in the former Soviet Union through poor medical practices before they even moved to Israel. And so that really helped change the perception and also provide some data to establish the different risk-sharing agreements that allowed for the introduction of the first direct-acting antivirals in Israel, which at the time accounted for 1/3 of the annual budget for that year. And so, especially given the cost of these treatments, there was an urgent need to quickly monitor and see are the drugs really working outside of the clinical trial setting. And we were quickly able to see that they were achieving rates above 95%, even 98% across different population groups. And that also helped to inform decision-making at the national level to expand access to these treatments, also to lower risk patients in 2017. And also, more at an internal level, we were also looking at different models of implementation of health services to help improve the speed and effectiveness of the delivery of these kind of therapies in the future. Moving on to big data, everyone's talking about big data. Usually we refer to it as the big unknown, and it covers everything that we haven't done yet. The potential is really quite astounding for healthcare. We can optimize treatment choices. We can personalize medicine and tailor it to the patient. We can help prevent human errors in many different ways. And of course, overall, with benefits for improving patient outcomes and for containing costs at the system level. When we talk about big data, though, people tend to use it in different ways. Sometimes it just means a lot of data, but that's not really what we usually mean. It's a combination of factors. Usually we refer to the variety of data, so moving beyond that structured data into different types such as texts and images and even voice. And I'll show you briefly some examples shortly. And also, when we talk about big data analytics, it's about the velocity and how you can actually deal with such vast amounts of information. But the key factor is about how you can bring value from such a vast quantity of data, how you can transform that data into something of value. This example here is the journey over just a few years about how actually our research institute got into big data at all. We didn't actually have any research capabilities in big data analytics, and it all started with this one patient who arrived at the clinic of the CEO of our institute, Professor Varda Shaleb. She's still a practicing family physician. This patient was diagnosed with colorectal cancer, and she just couldn't figure out what she had missed. There was no indication of anemia, nothing, but when she looked at his individual file, she saw a decline within the norm in hemoglobin levels. The next step was to turn to our epidemiology team and see, can we see similar things at the population level? And in fact, there were over 1,000 patients who had exactly the same thing 3 to 4 years before. They had some kind of signal in their hemoglobin that was different to the controls before the colorectal cancer. Now, again, we didn't really know where to go from here. And the only way we were able to move forward was by partnering with three guys who had left the finance world, who are algorithmics experts, and who were looking for some kind of value to move into healthcare research. And so we came with the idea and with the data, and they brought their analytical capabilities and helped make this possible. They built a predictive model that they were able to test internally and externally on a UK database using solely lab tests from complete blood counts, so the ones that we do all the time. What they found is that even with just one measure, you don't even need repeated measures over time. Just because of the relation between the parameters, there are enough abnormalities there to signal a high risk for colorectal cancer. And because our research institute sits within the health provider itself, we were able then to go back and pilot this risk score, implement it in the population that's already eligible for screening, who's supposed to be performing fecal-to-occult blood tests, but no one likes to perform FOBT tests. And so to just run this passive screening in the background, if the algorithm flags them as high risk, the physician gets an alert, high risk for colon cancer, this patient should get a colonoscopy. And what we found was that those patients who were referred to colonoscopies after this colon flag were actually much more likely to have a finding than those who were referred after FOBT. And within a year, that helped to identify over 200 patients who had either polyps or malignancies that otherwise wouldn't have been captured. The implications of this are that we can move to a model where people who are performing colonoscopies are actually much higher risk patients. And so instead of just adding colonoscopies to the system, we're actually shifting the model so that we have less clean, useless colonoscopies. And overall, this model is going to reduce costs, not to mention the longer-term cost of early detection of colorectal cancer and improving patient outcomes. Sometimes the data that we're looking for, it really is automatically collected. So when we're talking about genetic data and biomarkers, we thought we didn't have it, but it turns out that we could quite easily collect it by harnessing the existing infrastructure of the lab test delivery system in Maccabi. So with all these tests performed, the new project was launched last year to, at the sites of collection, so in your local clinic, when you come for a routine test, any kind of blood or urine test, or you'll be offered to join the biobank to see if you'd like to give your informed consent to give just a little bit more for research. So this way, patients aren't going out of their way. They're just at their normal interaction with the system, they can give a little bit more. And tipa in Hebrew means a drop. So would you like to give one extra drop of your sample? And within just a year, we have 50,000 members consented to join the biobank, and the collection of samples is growing really rapidly, and that's going to contribute a huge amount of data, valuable data, to help really move in the direction of personalized medicine. When we talk about big data variety, again, there's lots of different types of data. The text from the notes of the physician can be used to extract data, for example, on symptoms. So this K-Health app can be downloaded even in the App Store. This was an example of a partnership with a startup. We had the data, they brought the capabilities. They use natural language processing to extract the symptoms, to link them to outcome, and they provide an alternative to Dr. Google. So you can have a whole decision tree putting in your symptoms, and it'll tell you 90% of people like you. It's based on people in your age group and sex. 90% of people like you just had a tension headache, and they were fine. So you don't have to think that you always have a brain tumor. Other examples are looking at digital pathology to kind of provide a safety net. Now, we're not yet talking about replacing the pathologist, but at the moment it's implemented as a safety net in prostate cancer. So after the pathologist reviews the slides, they go through this machine learning algorithm. And already on the 4th day of implementing this method, we captured one patient, one case that the pathologist had missed. It was the end of the day, and they were tired, and the machine caught it when they had missed it. Partnerships with academia, we have some running projects in hypertension treatment to kind of optimize the choice of the most effective treatment. We also have one interesting partnership with another startup looking to try and extract data from voices. And this is another example of data that we didn't even realize we had collected. It's just through the call centers. Calls from chronic disease patients can be used to look for vocal biomarkers that predict conditions such as chronic heart failure, just from the different vibrations and frequencies in the voice, regardless of the content. E-prescription can be used to control, of course, minimize prescription errors. At the moment, we have a system of rule-based alerts to kind of minimize errors, but there are several options out there, and one that we are considering is, again, working with a startup that's established this machine learning methods that could help draw from data from the whole database, not just from clinical prescribing guidelines, to help flag outliers in the data and prevent often fatal errors. Now, everyone is talking about value-based, this is the end, value-based healthcare, and I hope that through these case studies, I've shown you a few examples. If there's one take-home message that I want to give you, is that data is the key resource, and that's what everyone's always talking about, but the key message from me is that it's really important to partner with different organizations to be able to, you can't expect one organization to have all of the capabilities, or even, so we work with academia, with industry, with startups, with pharma. We have some long-term strategic partners, and that's really the key to success. And thank you. I look forward to your questions. Thank you very much.